Hello everyone, this is Dr. Kim. Welcome to my radiology channel. This is where you're going to find anything that is interesting in radiology, dental radiology, and 3D printing and digital sensors. I know that's a topic that I haven't really talked about, but I think I'll be able to share a little bit more about digital sensors in the next several months because we're thinking about getting some new sensors for the school. So anyway, what I want to talk about in this case is we have a limited field of view of the patient's posterior left mandible where the providing doctor has done a beautiful job of placing graft. So this graft material has filled the extraction socket beautifully and it has integrated well and it's pretty much ready to go. At the same time, you notice that the surrounding bone is very sclerotic and dense. So what that suggests to me, I mean, look at that. I'm not seeing much of marrow space at all. It looks as if we have ridge made out of entire cortical bone, right? So, wow, I mean, that is a sclerotic trabecular bone. So that tells me that at the time of extraction, there was probably a long-lasting chronic kind of apical periodontitis along with condensing osteitis affecting this whole area. Hence, we have very sclerotic bone. Also, it may be that this patient just by chance has a very dense bone and dense and healthy bone. Look at the thickness of the cortical plate. I mean, that's very thick and that's good for the patient, right? Less likely that this patient will develop osteoporosis in, in an elderly age. But what I wanted to talk about is the incidental finding. As I scroll up and down, are you seeing anything unusual? And here again, and let me just put my crosshair to the area of interest. Okay, so where are we located? Well, this is approximately the area of missing, well, what should we say? Probably 31 or 32, right? It's located mesial or medial is probably a better term, medial to the area of missing 32. And how far are we away from mandible? About 4.7 millimeter, and here's a mandibular canal. Let's take a look at that in all three different planes. Let's see, can we see that here? Oh, vaguely. Let's see, there it is. So what could this be? Well, in order for me to answer that, we have to have a better understanding of anatomic structures. Also, keep that in mind that CBCT does not have good spatial contrast or resolution for soft tissues. So it's very difficult to make out which tissue we're looking at here. And that's where your gross anatomy information or knowledge comes in. Based on the location, I would presume that we're in the area of submandibular gland. And so when you see a calcification in the submandibular gland, I'm thinking of a sialolith. So now, do I know for sure whether this is in the sialolith or the duct, the Wharton's duct associated with this submandibular gland? I don't know for sure, right? Because again, I don't have that soft tissue contrast. But nevertheless, I mean, it is small and I doubt that patient is symptomatic. Doctor was unaware of pre-existing or condition of sialolith. But it's still important for me to catch something like this and bring it up to the referring doctor to correlate with any discomforts during the mealtime. So that's exactly what I did, and that referring doctor was very appreciative of such finding because, this people order limited field of view because they want to limit the risk of missing pathology, right, in other areas of the head and neck. So this doctor has done a good job of ordering a limited field of view, but the truth is most of us, at least the most referring doctors that I'm working with, their main focus is the area of where they're placing an implant. And so in this case, the referring doctor was completely unaware of this radial opacity. Anyway, that's really all I wanted to talk about. But as a side note, this case was interesting to me because of the increased sclerosis of the mandible. I could really see the pathways of wide range of neurovascular structure that are present in the mandible, which may not show up in other cases due to radiolucent appearance. But you see here, there is one, there is one, and there's one. It looks like it's coursing anteriorly. So that's really interesting for me to see something like that. And let's see if we can catch some of those canals. Here's one. Where is that going? All the way to the crest, right? And here's another one that goes to the crest. Why do I bring this up? Well, when I was at UCLA taking orofacial pain classes, the doctor often talked about patients suffering like unusual pain after extraction, just like a typical simple extraction with no surgical complications. But after that, patients develop weird like neurologic symptoms where they're constantly in pain, or even rubbing a cotton roll over the fully healed soft tissue area, the patient has that like burning and tingling sensation. So I always wondered whether even a routine atraumatic extraction could potentially damage these types of micro neurovascular bundles that are present. And I'm sure it varies tremendously from patient to patient. It's just an anatomic variation. We can never predict how much of these are present and its course of its pathway within the mandible. And I wonder whether that extraction could damage some of these nerves, which then could manifest clinically. So that's kind of my unproven hypothesis, just having looked at a lot of CBCT images over the years. Anyway, that's just for food for thought. And thank you again very much for your attention. And I'll see you in the next video. Take care, everyone. Bye.